My name is Ed Shahady. I'm here with Dr. Victor Tapson. I've been going over with him, and he and I have shared a lot of common paths, in the area of Raleigh-Durham, North Carolina. Also, you were in Gainesville, and his interest is pulmonary hypertension, and he's now in Los Angeles at Cedars Hospital there, and is in charge of pulmonary critical care medicine. He's going to talk to us about pulmonary hypertension, how we assess it, and from a primary care perspective. So, welcome.
Thanks, Ed. Nice to be here.
Yes, sir.
I think the most important thing, especially from a primary care perspective, is to just suspect the diagnosis. Have it on your list when someone comes in short of breath. The most common symptom by far of pulmonary hypertension is shortness of breath. Patients, if they're very severe, can have fatigue, can have chest pain. They certainly can have edema and other signs of right heart failure. But shortness of breath is a big symptom you got to be aware of.
But I probably think of so many other things. COPD, heart failure. So how do I tell you?
It's important you said that because I think the diagnosis of this disease is often delayed. Because of that, someone may have a little bit of COPD, or they may be overweight, or they had some childhood asthma, and their symptoms get blamed on something that really wasn't enough to really explain how severe the symptoms were. So it gets overlooked. And the average time from onset of symptoms to diagnosis of pulmonary hypertension is often over a year or a year and a half. So it's very frustrating. Many diseases can cause pulmonary hypertension. We always look for the cause of this disease. We always look at the severity. But as you pointed out, recognizing it is really important. If someone's short of breath and they're wheezing, if it is pulmonary hypertension, it's probably caused by underlying obstructive lung disease. Often with PAH, the lungs are clear. There may be some subtleties on the exam, a loud second heart sound. People aren't used to hearing that. They may pass it up. Tricuspid regurgitation murmur, they just pass it off as a systolic murmur. So it's a tricky diagnosis. There aren't a lot of specific symptoms and signs.
Okay, well, you just said something to be very helpful to me. You're going to be listening. If somebody comes in, they've got a smoking history, and it's progressive shortness of breath, and they're bringing up a lot of sputum, I'm going to be thinking COPD. But if they're with their shortness of breath, is the onset shorter or is it chronic, like COPD?
That's a great point. I think the onset of this dyspnea is usually chronic. It's long-term. So someone doesn't come in and say, I've been short of breath for 2 weeks. Right. It comes in, I've been short of breath for the last 6 months or so. I'll take a walk outside. I was fine, and then a couple of months ago, I had trouble walking up inclines. Right. Now I'm having trouble walking upstairs. It's been over months, sometimes even longer, but often over 6 months or longer.
Are there certain illnesses, like a pulmonary emboli or anything else, lung insults, that maybe lead up to pulmonary hypertension?
Absolutely, and we actually tend to divide pulmonary hypertension into 5 classes. Okay. Group 1 is PAH, or pulmonary arterial hypertension. PAH of unknown cause, things like scleroderma, and we actually have good drug therapy for that group. Group 2 is heart failure, left heart disease, it could be systolic or diastolic dysfunction, valvular heart disease. Group 3, COPD, severe sleep apnea, pulmonary fibrosis, lung problems, and hypoxemia. Group 4 is pulmonary embolism, and we do see that. Patients that have PE, sometimes the symptoms never go away. Sometimes they're never diagnosed with pulmonary embolism to begin with. And they present with shortness of breath, just like someone else with PH. And then you do that lung scan, and you see they've got chronic pulmonary embolism. Group 5 is a miscellaneous group. We don't have to spend a lot of time on, but so it's helpful to divide into these classes and when you're thinking about it.
So you tell me what makes you think of it, the shortness of breath over 6 months, gradually getting worse. And then what particular test am I going to get that might help me make the diagnosis?
Yeah, great point. So I think you're going to be thinking of other tests you do when someone's short of breath. You check their oxygen saturation, you might want to do a pulmonary function test. Right. But when you're thinking pH, whether it's you're thinking about some kind of heart problem or pulmonary hypertension, well, the echocardiogram is a pivotal test. It's not the ultimate diagnostic test we do. That's the right heart catheterization. But the echo gives you an idea. Is there evidence of pulmonary hypertension? Is there tricuspid regurgitation, a valve leak suggesting pH? Is the right ventricle normal in size and function? It might be. You might just have a little valve leak, an estimated pressure of, say, 50 or 60, and a normal right ventricle. The more abnormal the right heart is, the better, the more obvious.
So you're looking for right heart disease.
Absolutely.
That's
the key. Yeah, right heart. Now, there may be PH caused by left heart disease, and now there's right heart involvement too. That would be group 2 pulmonary hypertension. But the right heart's always involved with severe pulmonary hypertension, regardless of the class.
And then you make the diagnosis if you're suspicious. by right heart catheterization.
You got it. That's exactly right. There's one thing I think the family practitioner should know is this is often unexplained dyspnea. Echocardiogram is a good pivotal test to do first. And then as you just suggested, the right heart cath, that's how we make the diagnosis. As a matter of fact, that's the gold standard test. It's still recommended. I'm wondering if in 5 years or so, 10 years, echo techniques are improving, 3D, 4D echo, maybe we'll be able to make the diagnosis and be comfortable without invasive cath. Right now, the answer is still the right heart cath.
So if I'm suspicious, maybe get an echo.
Right.
And if that has some of the things you said, then send it to a pulmonologist, a cardiologist, a pulmonologist want to do right heart caths?
Sure, you know, it actually depends. At some centers, the pulmonary hypertension experts are pulmonologists. At some centers, it's a cardiologist. But I would recommend sending it to someone that does see PH patients and is involved in pulmonary hypertension. We even have some centers for excellence we're certifying right now. Certainly doesn't have to be a center like that. But the idea would be, if someone has some interest in PH, it's worth calling the referring hospital and saying, who does pulmonary hypertension? Is it cardiology, pulmonary? At our center at Cedars, I've got a colleague in cardiology that also does it. So 2 of us, pulmonary and cardiology. So it really depends more on the level of interest, but I think that's the specialty. Pulmonary, and if you're a smaller hospital, send them to the pulmonary guy or the cardiology guy and let them sort things out, and maybe they can do the referral for you. But I think the key is, family practice people have so many things to know and worry about. I don't know how you guys do it. I couldn't do it, I don't think. There's so many diseases to know about. This is one that's best referred to a specialist.
Well, yeah, we would agree. What I think from my perspective in primary care, I want to know how I differentiate it. And then once I've got suspicions, where I send the patient.
Sure.
So that's my job.
Sure.
And that fits in well with your job too.
Yeah, I think so. So when that echo comes back, the right ventricular systolic pressure, the estimated pulmonary artery pressure is 50 or 60, that's abnormal. And if the right ventricle level, that's abnormal. That requires some further evaluation.
Well, very good. Well, as far as therapy, we're not going to be treating, but are there any therapies, or most common therapy used, that there's some side effects we should be aware of?
Sure, probably so. I mean, we have 3 classes of medications. We look at the endothelin pathway. Endothelin's a very strong vasoconstrictor. We want to block that. The prostacyclin pathway, very strong vasodilator, triggers prostacyclins in some cases. And then the PDE5 inhibitors, we know from erectile dysfunction, sildenafil, tadalafil, we use those drugs as well. So it's a combination of therapies. The side effects can be acute with particular medication. It's worth a family practice doctor knowing that if you're on an ERA, an endothelin antagonist, you might get some fluid retention. It may not be from your pH, or might be from the drug. And you may get a hemodilution effect and actually get a little bit of anemia. Hemoglobin may drop a little bit due to the drug. PDE5 inhibitors can cause headache and nasal congestion and GERD sometimes. Prostanoids can cause some unusual side effects, headache, jaw pain, things like that. So if your patients are on those medications, we try to teach them as PH doctors what to expect. So they say, I've got a headache now, I just took my pill, that's probably what it is. So they at least have an idea, and it's not...
I would presume these people are older and maybe do have erectile dysfunction. They probably appreciate it.
Some do.
Some
can kill 2 birds with one stone, probably sometimes, that's right.
Excellent. Okay, why would I think of that? Okay, but thank you very much.
Thank you.
Appreciate
Nice
you
to see
being
you.
here with us.
My pleasure. Thanks for the invite.